Thank you, Mona. Someday we still want to see that performance. So as the first post-lunch speaker on day 2, I thought I would keep this relatively straightforward. Instead of getting too conceptual and complicated, I'm just going to tell you what's going on. Think of this as an expanded news flash, right? So for those of you who were there yesterday, this is not working. We learned something from the conference, and if it could be summarized in an aggregated statement, it might be that our digital lives and mobile device interactions are now fundamentally part of our everyday lives. Michelle Williams talked about this as an opportunity. Sandy Pentland talked about this as a new normal that snuck up on us so fast that we didn't even realize it. Now, as a clinician, I might take this one step further and say that if this is true, and we're taking at face value that it is, so the question is, if they are part of our everyday lives, should they be part of psychotherapy and mental health care as well? In the end, if psychotherapy and mental health care is about capturing and understanding patterns and variations in behavior, it should stand to reason that what's happening in our digital lives should be a part of this. Except this has come about so fast that I don't think the field has fully even begun to grapple with this change and how to bring digital life into the context of psychiatric care. So we've started looking at this now, and I'm going to review some work that we've done and work that's been done in the field around this. Think of it as first baby steps that are setting the stage for the field. This is a paper that came out a couple of months ago. A simple survey where they asked 82 patients in a tertiary mood and anxiety disorders clinic what sorts of mobile data were they willing to grant access to. This should be a foundational piece, right? Before you ask about people's digital lives, we sort of need to know, are they okay with sharing this even? And some interesting patterns come up. So the blue is all the stuff that they were willing to grant access to. And you see that the thing that they're most willing to grant access to is whether their screen was on or off, or motion sensors that were tracking how and why they were moving. They were more willing relatively to grant access to information on whether a specific app was installed or not. But if you look at the small blue lines, those are the data that you could interpret as more personal. Audio keywords or audio conversations. In other words, the content of what the phone was being used for in terms of phone calls. Or information from their SMS or metadata from SMS. And I think the overriding conclusion of this study was that things that are of a more personal nature, people are less keen to give access to. Now, this should surprise nobody, except the context of psychotherapy is a little bit different. The whole point of psychotherapy is sharing what's a little bit more personal in a protected, secure, confidential environment where you can bring up this stuff and if it's problematic, have it dealt with. So we've been thinking about this at McLean amongst a pool of clinicians affiliated with the Tech Institute. And we decided that if you're going to venture into these waters, maybe we start with seeing what's already happening out there, because if it's already happening before anyone's done anything about it, then you assume it happened naturalistically, which is a pretty good marker of whether this is going to stick or not. So we did a little survey, and these were the questions. What are clinicians' attitudes around accessing social and electronic media? To what extent are our clinicians currently using this as part of everyday care? So not a research intervention, not a study. If they are, what are the most common motivations for accessing this? What are the reasons for not viewing electronic data? And are there any concerns about privacy? So this was not sophisticated at all. It was a 17-question survey made using Google Forms. We used a little bit of existing survey literature to help us plan out what we wanted to do. But I work with the best research assistants on the planet. They whipped this up in about 2 days. We piloted it. It seemed good. We sent it to 244 outpatient psychotherapists associated with McLean Hospital. Absolute sample of convenience, right? We got 15 out-of-office replies. So it was an actual sample of 229, and we got 115 respondents. So a response rate of almost exactly 50%. That's about 10% higher than the average response rate for a survey of this kind. We kept it open for about 2 months. Simple questions around what our therapist's highest degree was, their years of experience, and whether they viewed patient social or electronic media as part of a therapy session at any point. And if they did, we asked more questions around the clinical context of accessing this. And we found that 62% reported that they had viewed social or electronic media. And by electronic media, we mean everything that's on the phone, but that's not part of social media. But then interesting patterns started to emerge. So for clinicians that had it says less more. That's an embarrassing typo that I just picked up. I hate when that happens. 46% of clinicians with more than 20 years of experience had accessed these data. This number goes up to 69% for those with 10 to 20 years of experience, and 70% with those who had less than 10 years of experience. There was a large pool of residents in this. So people that were, or therapists that were more native to electronic media seemed to turn to this with much higher frequency than those that had more experience but were perhaps not natives. Interesting finding, not surprising, but nice to see it play out in a survey. And viewing rates did not vary by highest professional degree. So we had MDs, PhDs, social workers, licensed mental health counselors across the training spectrum. We wanted to know who raised the idea of using these data. And 74% of the respondent clinicians said it was their idea, 14% indicated it was patient's idea, and 10% said that it was through a mutual suggestion. We asked if privacy had been a consideration, and 62% reported discussing privacy, a high number, but when you break it down, the conversation around privacy was initiated 97% of the time by the clinicians themselves. Only 3%, and that effectively was one clinician who reported that the patient brought up a concern about privacy in letting their therapist access their electronic data. This is interesting because it tells us that people seem to be a little bit less concerned about the privacy of their conversations in the context of psychotherapy. There's something there. We don't know what, we don't know how we can use it, but therapy works differently from conversations at large. If you asked how many people were comfortable with Google getting their data, or Facebook, or the feds, we might not get a number as low as 3%. As a clinician, I find this reassuring because it tells you that maybe the doctor-patient relationship remains sacred after all. We asked what type of media were accessed, and overwhelmingly, text or email, more so than Facebook or call history or Instagram, blogs, Twitter, Snapchat. Only 7 people accessed WhatsApp. But we made the different distinction between WhatsApp and text messaging. There may have been some overlap. This was not a very detailed survey. It took about 7 minutes to complete. So while the research may look more at social media, the signals may lie in more private conversations, which are easier to access in the context of therapy rather than research at large. We asked how they accessed it. And again, interesting, 90% of them viewed the content directly in the presence of their patients. So essentially, the patient gave them their cell phone or allowed them to log into their emails. 67% patient self-report, followed by small number with outside of the session with the patient's consent, or a report from friends or relatives. So the best way to access this turns out to be with the patient present, so they know exactly what you're looking at and why with the patient present. For what disorders did they look at it? Primarily anxiety and depression. Borderline personality disorder was number 3 on that list. This may represent a McLean Hospital bias. I think McLean is known for its expertise in treating personality disorders. We're not sure if this would reflect the community at large. These results should be replicated. And then PTSD, bipolar, psychosis, OCD, and eating disorders. This is my favorite slide. 92% of clinicians felt that viewing this content improved their ability to provide effective clinical care. Again, should surprise nobody, because for years, patients have told us about conversations they have, or brought in letters, or reported things that happened over a phone call. It's just that now it's in text form, and you're actually getting to see it and read it. But still, nice to see that this is the digital translation of a more ancient therapeutic process rather than some new revolutionary thing. 24% reported significant improvement, 42% moderate, and 25% slight improvement, but a good value proposition. So this then raises the question of, if they're looking at this, are there in fact signals in text information that we can leverage for deeper understanding into symptomatology itself? So we've been looking at the literature because other people have delved into it. We had a very sophisticated session on natural language processing just before this. A recent study found that Facebook language can predict depression in medical records. There was an older paper, and that was in PNAS. There was a paper in PLOS ONE that claims Twitter is a good place to detect health conditions. And some may think that you can even use Twitter data to forecast the onset and course of mental illness. The conundrum here is that this is done with large volumes of data. Can you actually translate it to the individual? We don't know the answer, but that's the next piece that needs to be figured out. How can you take empirical patterns and empirical predictability and translate into something that has meaning in a one-on-one situation between the therapist and their client? So we're now thinking about what the ideal clinical workflow would look like if you're going to tap into this systematically. So right now, this is how it goes. Patient arrives for a visit. The mobile device accompanies the patient, because mobile devices accompany everybody at all times. And the session begins. Then there is a very simple sounding and extremely complicated amount of computing that needs to happen in the background. There has to be consent to extract these communications, because really a therapist can be going through all of this during the course of a session. There is simply not enough time because there's so much information. So we would like this to be digitized somehow with the patient's consent. We would like for there to be natural language processing. I won't go into details of that, but a way to tease out what words are markers. Not enough to have suicide or depression, apparently. I would be curious personally if there was a data set that associated phrases about wanting to shoot themselves with Astros, Dodgers, or Yankees in the past month. That should tell you about what kinds of biases may exist. There would need to be algorithmic extraction of content aggregated into a dashboard. This is something that a therapist would need to happen, invented by many of the people in this room. If you do that, then you can incorporate all of this seamlessly into the start of a session, and all it really is collateral information, and then look into whether digital content is reviewed or not, and turn it into digital actionability. The 4 colored boxes represent 4 giant domains in different stages of maturation. But really, if all of this is going to make a difference, you need to work it into that seamless workflow. So we think a good way forward is better characterization of the value of these data in therapy. Again, 92% of clinicians reported in an open survey that this content improves care. So it goes to say that we will need best practice standards to guide the appropriate and access to this content. There are thorny questions about who owns the data that we'll discuss later in today's session, and that there is great potential and cautious progress. I want to acknowledge the work of people that have helped us get this work started, and I think the next 3 talks focus on how we actually go about building the digital tools to make this happen. But I think there is clear value proposition in this. Thank you.